Hello dears, in this video I will explain the tracheostomy, which is life-saving procedure. Every doctor should learn this skill. Tracheostomy is a procedure to relieve airway obstruction by creating a direct entrance into the trachea through the neck. It can be performed in emergencies when intubation is not possible, but it can be challenging, especially in obese patients. For less experienced individuals, inserting a large intravenous cannula or small tube into the cricothyroid membrane can be easier. Ideally, tracheostomy should be performed when first deemed necessary. Prior to the procedure, if time permits, inspect and palpate the neck to assess laryngotracheal anatomy. Perform indirect or direct laryngoscopy. Evaluate pulmonary function via auscultation. Explain to the patient that they will be unable to speak immediately post-operation and reassure them about the temporary nature of this effect. In a can't intubate, can't oxygenate situation, following failed attempts with face mask, supraglottic airway device, and endotracheal tube, emergency front of neck access options like cricothyroidotomy or tracheostomy should be utilized to avoid hypoxia. Emergency tracheostomy. If no skilled anesthetist is available, local anesthesia is used, but none is needed if the patient is unconscious. For severe head and neck trauma or unstable cervical spine fractures, cricothyroidotomy is preferable. The patient should be supine with shoulder padding to aid in neck palpation. In small children and thick-necked adults, identifying landmarks is more difficult. A vertical midline incision is made from the thyroid cartilage to the suprasternal notch. In case of heavy bleeding, continue without controlling hemorrhage immediately. Feel for the cricoid cartilage, make a vertical incision through the trachea, and insert a tube. Secure hemostasis and refashion the tracheostomy if necessary. Elective tracheostomy allows for complete airway control, unhurried dissection, and careful tube placement. Requires close cooperation between the surgeon, anesthetist, and scrub nurse. After induction of general anesthesia, position the patient with head extension and shoulder padding. Use a transverse incision, divide the thyroid isthmus carefully, and insert a tracheostomy tube. Monitor tube cuff pressure to prevent mucosal damage. Percutaneous tracheostomy. Performed in critical care settings with intubated patients. A transverse skin incision is made at the tracheal rings, followed by blunt dissection and guide wire insertion. Sequential dilators create the tracheostom, and the tracheotomy tube is placed along the guide wire. Patients must have suitable anatomy and unrestricted neck movement. If doubt arises, a surgical approach is preferable. Tracheostomy tubes, made of plastic, come in various sizes, and include cuffs, inner tubes, and speaking valves. Initially, a cuff tube is used to protect the airway, which is changed after 3 to 4 days. Secure the tube with double tapes or stitch the flanges to the neck skin. Use a removable inner tube to prevent lumen occlusion. Advantages of tracheostomy: reduces anatomical dead space by 50%. Decreases work of breathing. Increases alveolar ventilation. Decreases sedation needed for patient comfort. Disadvantages of tracheostomy: loss of heat and moisture exchange. Desiccation of tracheal epithelium and loss of ciliated cells. Increased mucus production and risk of tube blockage. Potential aspiration due to splinting of the larynx. Postoperative care includes frequent suction and humidification to maintain a clear airway and prevent complications.